Rachel, everybody can hear me? Okay. All right, everybody. So I'm just going to go ahead and give everybody just a couple more, at least another minute or two to go ahead and join in.
Bye. Yeah.
Everyone, my name is Kelly Sandaker. I'm the SURSAC administrator for this group, and I want to just go ahead and introduce myself and go ahead and get started with the disclaimer. This meeting is being recorded and live streamed on TPW. This meeting will be shared on the State B. Blake ESB 5476 page. This recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. There will be 10 minutes at the beginning of the meeting and 10 more minutes near the end of the meeting reserved for public comment. Each person will have 3 minutes to provide feedback. If you are not a committee member and you would like to make a comment during a particular discussion, please raise your hand for facilitator awareness and public comment on the topic. You will be invited before moving to the next item. Feedback that is not provided during the meeting can be submitted via email at any time to hca.esb5476@hca.wa.gov. I'll now go ahead and move into attendance. Jason McGill. Michelle Martinez. Present. Blake Ellison.
Present.
Sarah Melfi-Klein.
Present. Good morning.
Morning. Tony Walton. Brianna Peterson.
Present.
Ken Cadella.
Good morning.
Rachel Downs. Haley Fuller. Alex Sheehan. Amber Leaders. Senator McDingra. Senator John Brown. Representative Lauren Davis.
Good morning.
Morning.
I'm actually on a plane, so I will have to jump when they close the boarding door, but thought I'd be here for the first part.
Okay, great to have you, Representative Lauren Davis. Representative Dan Griffey. Caleb Benzagreen.
Good morning. Happy Monday.
Morning. Don Julian Saucer. Sean Meyer. Alexa Orr.
Good morning.
Morning. Amber Cope. Brandy Flood. Stormy Howe.
Good morning. Present.
Morning. Chad Enright.
I'm here.
John Hayden.
Good morning.
Nikki Lewis. Jerry Candelero.
Good morning.
Morning. James Tillett.
Good morning.
Morning. Christine Lynch.
Good morning.
Morning. Sarah Gillard. Donnell Tanksley. Okay. Malika Lamont.
Present.
Addie Adwell.
Present.
Kevin Ballard.
Good morning.
Morning. Hunter McKim.
Good morning.
Representative Jamila Taylor. Representative Gina Mossbroker.
Good morning. Thank you. We're looking forward to the meeting.
Morning. Just a quick reminder, just the only announcement we really have is that I sent out a email for a vote. I did get quite a few back, but if you haven't responded, if you want to respond during this meeting, that's totally and absolutely okay. If you just want to respond with the letter to make it the quickest possible, you can. Before we move on to Blake Ellison for public comment, We had put down 55368 section 8.2 for public comment today. That was a mistake on my part. I'm really sorry about that. We've already spoke about that. We had, DOH already speak on that and everything like that. And that was already talked about at the previous meeting. And I put that on there by mistake. I'm sorry about that. Okay. And Sarah will provide a welcome.
Morning, everybody. Sorry, 1 second. Hi, everyone. My name is Sarah Melfi-Klein. Sorry about that. Oh. Technical difficulties. All right, hopefully that echo is gone now. My name is Sarah Melfi-Klein. I am here at the Healthcare Authority, supervising a team at the Division of Behavioral Health and Recovery, Adult Substance Use and Treatment Section. I'm stepping in as Michael's role today as chair, as he and Tony are out at NASDAD, so wanted to provide a welcome as Michael typically does. And some of you might remember I was formerly on the SURSAC as the managed care representative in my previous life, and actually for the last 11 months have been at HCA continuing this important work from a different angle, largely supporting and implementing programs that came out of the State versus Blake decision and resulting legislation, and specifically some of the programs recommended by this committee. So in opening the meeting today, I want to draw attention specifically to give acknowledgement to one of those programs in particular and recognize the role of the voices on this committee in bringing that program to fruition. In late 2022, this committee made a series of 17 recommendations to the legislature, which were ultimately published as the State Substance Use Recovery Services Plan. Recommendation 7, Health Engagement Hubs, involved co-locating medical, social, and harm reduction services in a low barrier setting meant to support the needs of people who use drugs in ways that the traditional medical model has failed them. So last month at the SURSAC, Tim and I presented on progress to date in implementing 2 sites in Washington State and our plans for expansion to 3 more, currently accepting responses from interested programs due June 14th. And I just wanted to share today that Washington's innovative comprehensive model gained the attention of federal legislators. And just a bit over a week ago, U.S. Senator Maria Cantwell introduced a bill to take this model nationwide. So I'll pop that in the chat here once I'm done so that folks can take a look at that at their leisure. But really just wanted to take a moment to acknowledge the collaborative efforts across stakeholders and agency systems to elevate the voices of people who use drugs to impact state and now proposed national policy to make healthcare more accessible to this population. Specifically, the efforts of this committee and the treatment subcommittee who developed and put forth this comprehensive recommendation, which was ultimately adopted by the Washington State Legislature. In addition, the State Opioid and Overdose Response Plan Goal 3 work group, who originally developed the Health Engagement Hubs concept and endorsed this committee's recommendation. The Healthcare Authority couldn't have operationalized Health Engagement Hubs without the expertise of Department of Health and their 30+ years of directly supporting low barrier harm reduction programs. Additionally, our thought partners at University of Washington Addictions, Drug and Alcohol Institute, both for their research and interviews of syringe service program participants, and in really informing that low barrier buprenorphine aspects of the Health Engagement Hub model through years of implementation at several sites across Washington. Of course, our 2 inaugural sites, which we shared last time, Blue Mountain Heart to Heart in Walla Walla and Health Point Auburn, will be our first 2 health engagement hubs in Washington State. And most importantly, and at the center of all of this, those willing to share their lived and living experiences to inform the shift in our treatment landscape and help us reimagine how we can make healthcare delivery system work for some of those most at risk of adverse health consequences. I'm incredibly excited to see where this program goes, and that's just one of many recommendations this committee has made that's been adopted by the legislature and impacted our state's substance use and treatment service landscape in the midst of an overdose crisis. So in closing the opening, I just really want to thank you all for your time and commitment to this work and remind you that your knowledge and your voice matter. And so glad you're here today. And I'll hand it back to you, Kelly.
Thank you, Sarah. I think we can actually move it on to Blake Ellison for he can start doing his part. Blake, you want to go ahead and take it?
You bet. Good morning, folks. It is time for public comment. So anybody, member of the public who would like to make comments on a topic related to SURSAC and our work, now's the time. So please go ahead and raise your hand in the chat. and we will call on you. Again, any public comment is welcome now. If you want to make a public comment, then please raise your hand in the chat virtually, and we will call on you. Okay, it doesn't look like we have any takers this morning. Last call for public comment. Okay. All right, so next item on the agenda is any walk-on items. Is there anything that we want to discuss at the end of the meeting that maybe is not on the agenda? Anything we want to add? And if you want to add something, please go ahead and raise your hand in the chat. I will call on you. Okay, again, walk-on items. Anything that you want to add to the agenda? All right, we'll move on to item number 4. Aaron, are you here? I think I see you.
I am, but I'm in my car, so I'm not going to be on camera.
Okay, we're going to talk about the Icelandic model. So, Aaron, whenever you're ready.
Yeah, ready now. Thanks so much, everybody. My name is Aaron Spark. I'm an enrolled member of the Chivak Native Village Nishnawbe tribe. Thank you for allowing me to be here and doing my part for our communities. I am the Office of Tribal Affairs Administrator here at the Healthcare Authority, a whole 1 year and 10 months old. And very soon after I started, less than a month after I started, we had the Centennial Accord in 2022, where the tribes have the ability to consult directly with the governor. It's one of the things that makes the state of Washington wholly unique in the United States, that the federal trust responsibility is carried by the state of Washington also, and not just the federal government, where the tribes have the ability to work directly with the executive as well as their executive branch secretaries and cabinet. So during that time, we had heard from the tribes that we are going through a crisis that was hitting Indian country a heck of a lot harder than it was anybody else. During the pandemic, we had lost 6.6 years of our life expectancy as a people. And also we have learned that we are 3 times more likely to die of opioid-related overdose deaths than any other ethnic group. So during that time, we had heard we can't do this alone. We need your help. We're trying. But the Indian Health Service system is one of the woefully underfunded system, and it has been since inception. So the tribes are asking the state, we should do this as a partner, and Governor Inslee responded, and he said at that meeting, let's go ahead and do this. Let's have a conversation a little bit further. And we had heard about this Icelandic prevention model. The Lummi Nation is the one who instigated. They're the one who started this first by sending a youth group over there to find out what's the best way to start treating our youth. And they came back and tasked their tribal council with, this is something that we want to do. Knowing that this is a pretty big endeavor, the tribe had asked the state for some help, but we heard from just about every tribe out there that we all need this help. So thank you for everything that we're doing right now for acute care, but we need to start thinking about doing something upstream. That led to a trip to Iceland between the state of Washington, where the representatives of the Healthcare Authority, the Office of the Governor, and 5 self-selected tribes or volunteers to go along to view what's called the Icelandic prevention model. And over a 28-year period, Iceland had gone from worst to first in substance use disorder, which is a pretty impressive thing, to the point when we're walking along and talking to the youth while we're over there, we asked, what is it like growing up in the Icelandic prevention system model? And then very honestly, the answer was, what's the Icelandic prevention model? And that's where we want to be. We're a couple of generations removed. We are now having children who are so protected and involved in their communities that they don't know that they're in a prevention model. That's where we want to get to, and not in a place where an Indian country, a tribal leader, Councilman Nick Lewis, said our kids are more used to going to funerals than they are going to birthday parties. So that's the place that we wanted to get to. And what we noticed is that there's an interplay of 6 different domains that the government had taken control over, which is government, health, human services, youth services, justice, and education. Now, that's a lot to talk about when you're talking about government, and each one of those is a universe unto itself. So as the state representatives, when we're looking at this, we're not thinking that this can necessarily happen in a municipal setting, but where it can happen is in a tribal setting where a tribal government does have direct purview over all 6 of those domains. And it's also built upon a cultural model where many of the tribes have strength in those areas. They just don't have a whole lot of resources to deal with. I know that's going to sound a little interesting to folks because you think, well, tribes are not necessarily taxed. They have the casino system, but understand the majority of the casinos are not profitable in the United States. That is a fact. So, and not only that, but with the federal trust responsibility not being funded at full levels, you're talking about pennies on the dollar for any one of these systems that we're talking about. So these 5 tribes have now said, we're ready to do this along with the state, to hop into this. It was with a group called Planet Youth that runs it over in Iceland to disseminate this model all throughout the world. And this is a data-driven model. Everything about this is predicated on being able to take data and data points multiple times per year to figure out if your programming is working. So now that we're at this point, we've done a year of work with the tribes, very high-level government-to-government work, which is why I don't have a PowerPoint presentation for you right now because the contracts aren't signed. But there is preliminary funding for year 1 of this system, which is very exciting, but also very daunting. These are 5 very, very brave tribes that stepped forward and volunteered to say this is something that we want to do, because the fact is, this isn't just for Indian country, this is for the state of Washington. The very first thing that Governor Inslee said when he heard about this and we got back and we gave our full report was, can this happen in the entire state? And the thought is we would like that to happen, but there does have to be a pilot. And this pilot, it's not a small endeavor. This is a 10-year pilot life. The first year is just feasibility and hopefully having a pro forma over the 10 years that's going to happen after year 1. And we're not going to have utilizable data until year 5. So this is a big thing, knowing that you're going to be changing almost your entire government system to attempt this. But the fact is we have too much youth and so much of our future being stolen from us right now because of the opioid and fentanyl crisis that we're facing, that something has to be done. And I'm extremely honored to be a part of this process, knowing that, we have a lot of brave volunteers that go out and say, we're going to do this for the state, and at a great cost to themselves. So at the moment, there is some funding that came in from the state, and we're looking elsewhere. This is about a $20 to $25 million project over 10 years, which at $2 to $2.5 million isn't that big of a cost when you think about it on the grand scale. But for 5 tribes, that is an extremely high cost. We have received about $1.35 million, about $350,000 from the Healthcare Authority to contract with Planet Youth for the 5 tribes and us. And also the state legislature and the governor thankfully gave $1 million to stand up this program, which works out to about $166K per entity to hire their project manager for year 1. So that's where we are. But I also want to point out that this is much different because we're talking about people who have federal rights to confer and work with the government. So this is a very different thing, understanding that when we're talking about the tribal piece, this isn't just a DEI initiative. These are based on federal and state statutes that we do have to follow. But it's something that we look for. And as tribal community members, what we're doing is making sure that whatever we do, we want it to be replicated for everybody else. Because I think ultimately the tribal aspect of the United States is that form of DEI that every other BIPOC group wants to get to, where there are federal and state protections in order to work with them to lift up our communities. So that's the Icelandic prevention model. I do want to let you know that because we've hit the tribes with so many different models, that the tribes elected not to call it that, because so many times we hit them with 3-year funding models on something, and if it doesn't work, there's no sustainability. So we call this the Washington State Tribal Prevention System, and now the tribes have started calling it the North Star because we're aligning so many government systems in alignment towards a single goal, which is protecting our children and treating our community as a client. So I'm happy to take any questions here, any concerns. And this is something that we're working on. Again, we haven't even entered into year 1, so I can't give you any results yet. but happy to have the conversation.
Thank you, Aaron. Questions for Aaron? Any questions for Aaron?
Yeah, I have a question for Aaron. This is Kevin Ballard from DuPont.
Go ahead, Kevin.
Yeah, Aaron, I'm just interested because I don't know. Can you describe overall the mechanism for how healthcare is paid for within the Native populations locally and broadly? Is it fully funded by the tribes and the federal government, or is it private as well?
So I'd like to say it's not fully funded in any kind of a way. There was a government report that came out where it says that based on the treaty rights and the system cost itself, we're funded at about 35%, but that's with an undercount of all our tribal communities. So really, we're talking about in the 20% really margin. But there is a treaty right through the Indian Health Service if a tribe is either a tribal 638, which means that they have self-autonomy, or they have an Indian Health Service hospital, or that's paid for that way. So it is either up to the tribe, and all tribes in the state of Washington have some form of tribal 638 aspect where they have self-autonomy over healthcare. So they do get some money from the federal government. They do get some money from the state. Understand that when we're talking about things like Medicaid, all of that is federal dollars. We just get a federal share of it that goes to the state where we have control over how it's spent. So they have access to those systems just like anybody else does. Some of it does come in from the federal government.
Yeah, and
But then
the
again,
reason
a lot of that cost comes in from the tribes too. There's a lot of internal costs. And that's honestly money that's not being spent that they don't even have. So it's an interesting system that we have.
Yeah, and I figured as much. Looking at the Icelandic model, they have a fully funded healthcare system on the taxpayers pay for it. It's considered part of their welfare system. So I'm wondering if this initial trial, given the nature of how the Icelandic model is fully scalable for the general population in our current healthcare model.
Yeah, it's not predicated on a model that's going to pay for 100% of your healthcare. That's just not something that exists there. But if you heard the domains that I'm talking about, largely it's a planning endeavor that's going to be undertaken to align government systems to start saying resources can be used in a certain kind of a way. Unless universal healthcare is approved in the United States, which I think all of us who just watch even at a casual level know that that's pretty far from happening. That's not what we're trying to accomplish. But what we're trying to accomplish is a large-scale community planning model that's going to address the crisis, to be able to create community supports that are going to give children, until the time they go to sleep, and families, the tools in order to be successful and to reduce risky behavior.
Outstanding. Hey, thank you for your brief today. It was very informative.
Yeah, thank you for your question.
Any other questions for Aaron? Okay, thank you so much, Aaron. Appreciate
thank
the time.
you for having me.
Oh, we got one more question. You still there?
Yeah, I'm here.
All right, Malika, go ahead.
Hi, Aaron. Thank you for providing the information that you've shared today. And I'm wondering, so is not I am glad that the support is coming and that people want to engage in the process. My concern becomes, from the support being delivered from the federal government and from state government, that, oftentimes a lot of planning happens, but then the support doesn't always necessarily follow. Is there a plan B if that doesn't, or is that part of the planning process, so that if like the needed supports are not in alignment with what gets planned?
Yeah, that's an excellent question. Honestly, there are plans B through D if we're talking about it, because we need help on this one. Obviously, this thing that when we modeled it out cost about $2 to $2.5 million a year. We got $1 million in public funds, so we are working with the federal government. We're working with private donors and charitable foundations as well to see if we can't do this. We're going to go to Native Americans in philanthropy and the larger philanthropy group that's later. Because really, at the moment, what we're trying to do is with year one, we're going to create that pro forma, and we are going to come back to the state and see if there's any funds. But that's not stopping us from going out and asking, hey, is there somebody out there who wants to give us 5 years of funding? Can you give us $10 million to make sure that we can get to the point of utilizable data? So yeah, there are a lot of funds. It's definitely on our minds, knowing that public health systems, especially with prevention models, aren't necessarily something that are prioritized in spending in healthcare systems. So it is on our mind. There's a lot that that we have going on, and we have a core group of those elected tribal officials, along with a small group here at the state that are fully dedicated to talking with other groups to find out where's the interest. And the interest is high. We've had federal agencies who have now gone to Iceland to go and tour this model after what they've heard from us. And now they're much more interested in saying, hey, we do want to see what this is. There's so many communities out there going through nationwide that they want to help impact and get that upstream planning model implemented.
Awesome. Thank you.
Yeah, thank you for your question.
All right. Any more questions for Aaron? Okay, thank you, Aaron. Appreciate your time.
Yeah, thank you, everybody. Bye now.
Okay. All right, next up, RNP report. Brianna, you ready to go?
Yep.
All right.
Hoping everyone can hear me. If you can't, please make a note in the chat and we can work on it. Hello and welcome, everyone. This is the Recovery Navigator Program quarterly report. This report is based on the Q1 data, which covers January 2024 to March 2024. In this report, we will. This report will cover updates on the report and dashboard, the referral and outreach data, and the case management data. I do want to give a quick update on the dashboard. We are still working on it. We are making progress. It's a little bit slower. We ran into a couple of bugs and issues. Hoping to have something probably in between this and the next reporting period, providing you guys a link with the public dashboard. And so I will probably be presenting that in September. I will be showing some slides of what it looks like and asking for a little bit of feedback during that time as well. So be prepared if you have any comments or feedback on it. I do also want to address Caleb's suggestion at the last report about reverse engineering the case management data to be able to fill in the gaps for referral and outreach. I did talk to the data team. They're currently not at capacity or have the tools capable to do that at the moment. We are still looking into different modes of being able to capture that information, but we're just kind of like trekking through the mud at this point. But we are hoping to come out on the other side with a clear, definitive answer as to our capabilities to do that. Go to the next slide. We will continue to collaborate with the data group to update and publish the public dashboard. And we hope to, again, have something in between now and September. We previously intended to show regional data, but that's kind of where we caught our bugs, is when we were going through the regional data, so we were not able to present that information at this time. Please take note of the table on the screen of the timeline for the meetings and the tentative reporting schedule throughout the rest of the year. We previously had shared the process of how we determine the estimated number of unique clients, and we will continue to make improvements to make sure that those numbers are as accurate as we can possibly get. According to the data, there were 8,712 outreach encounters,
which came from 3,688 unique clients. Keep in mind that some people may require multiple outreach encounters before accepting a referral, while others may accept it right away. Therefore, the average ratio of encounters to referrals is around 2 to 1, but it may not be the case for everyone. Social and diversion law enforcement contacts are collected when determining the number of law enforcement referrals. We're currently sitting at 17% for those referrals based on the, and for Q1 data when it comes to law enforcement. I was talking internally with my group, and as we were reflecting on the top referral reasons, we thought it'd be kind of interesting to see a trend line for a whole state fiscal year, which is the next, how we'll report the next in September. Trend lines of the referral reasons. When I was reviewing this information based on the previous, I saw some shifts. There was an increase in trespassing and a little less with interfering with business. And so I thought it'd be quite interesting to see how those trends throughout the year. I was curious if anybody had any feedback on what other kinds of trends they would like to see based on the current data that we're seeing right now. Either, the estimated duplicated clients, encounters, law enforcement. I thought that would be helpful. So yeah, I see a couple of hands. If you guys have feedback, I'm happy to take it.
Malika, you were first.
So I'm curious, of these law enforcement referrals, how many of them are arrest diversions? And also that's something that I feel like would be really important to get at. And also, instead of, I mean, it's concerning to me, and I've said this before, so I'm just gonna, continue to beat this drum, that we can't get an actual of the unduplicated clients. And referral and outreach is one thing, but like ongoing encounters in order to support people, like that would be more meaningful to me, to see how folks are, like how frequently they're having engagement, to help them move along the cycle of behavior change. Because from what I'm seeing from this, so this is my question, this is actually a question though. So with the referral and outreach, you're saying that there's 2 encounters to every referral during outreach. Does that mean total contacts, or does that mean before they sign the multi-party ROI and engage in services?
Yes, that's before they sign the ROIs and are, you'll see on the next slide, but it's before they engage into either light case management or intensive case management, and then they'll shift from here to the case management information.
Okay, thanks.
Thank you.
Kelly, do we have is it okay if we take a quick question from Susan? Okay, yes, Susan, please. Go ahead. Or Brianna. Susan, go ahead.
Yeah, thank you. I am, I'm not a member, but I raised my hand. So if it's appropriate to ask a question a later time, that's fine. But if there's time now, that's great. Just, I know that the way the workbooks are set up right now, I don't think we capture this, but if we're talking about things we'd like to see, a trend in our region is arrest for not just possession, but public use. And so I'm just throwing that out as a trend that would be interesting to follow if we were able to. That's it. Thanks.
Thank you.
Yeah, I was myself, I was considering, the criminal justice piece of it, like the pretrial and like the prosecutor's office that make referrals to this program as well, kind of trying to capture those, how many were coming from there, because we were seeing a lower number in law enforcement referrals. And so I really want to be able to address in some way what the other referrals look like as well, because I think that that's also important. I know just speaking with the providers and the ASOs, like, there's a lot of community and business referrals that are coming in as well. And, those could be before they, contact law enforcement. And so there's a lot of pieces going on that we're not seeing as a whole right now. And I just wanted to, you know, get some feedback on how can we frame this to get a better whole picture of what's going on with R&P. So thank you, Susan. Appreciate it. Next slide. Out of the, oh, we have another hand up, Malika.
Well, to answer that last question you asked about how you can get a better idea of what's going on with R&P is to have a comprehensive data collection system. A spreadsheet is not going to be able to capture that for you.
Yeah, and we are working towards it currently. We're having multiple conversations about what that looks like and looking at different vendors. We are having internal meetings regarding the data and data collection. I know there's a couple of mandates in 5536 for a data integration model, and we are making strides to get that completed for, is it this next year?
The data diversion integration.
Yes.
Yeah, I
Well-
think that's in 2025.
In 2025.
Okay, well, for the sake of the SURSAC group, the state has already made huge investments in Gelada, which has actually created a data framework for the lead model, which R&P is supposed to be based upon. So there is something that's out there that does that. And they have been responsive to like all of the different way, and it's got a case management input system, as well as a way for other entities to extract data that is HIPAA compliant and 42 CFR compliant, as well as for other the entities that need to input data so that you could have a more comprehensive picture about what's going on. The state's already made huge investments since 2019 in that. So I just wanted to put that information out there for the rest of the SURSAC members that might not be aware of that.
Yeah, actually, I think we have a message out to Lisa to do some demoing for our data group to see if that's something that we were able to utilize. So yeah, we are having those conversations.
Lisa wouldn't be the person to do, Lisa Dugard would not be the person to do that. The people at Gelada would be the people to do that.
Oh, Rebecca, is it Rebecca?
Again, I mean, Rebecca's on my.
I just wanted to reiterate that
Can do.
we're having those conversations regarding Gelada, and we're just including our data folks internally at HCA at CQCT to participate in the demoing of that program, and also if we can utilize it or not. There is a decision package that we've submitted to get more funding for it as well. So there's a lot of wheels are turning. We just don't have anything definitive right now. I hope that was able to address your concern and comment. Of the 3,688 from the slide slide and the referral and outreach, 252 were enrolled in intensive case management and 400 were enrolled in light case management for this quarter. This leaves a number of individuals in outreach status. Outreach coordinators will continue to build relationships with those individuals to actively enroll and convert into light case management or intensive case management. I would like to make a couple of notes. Oh, Deontay, yes.
Hi, everyone. I'm just looking on, I'm looking on the graph that we have in front of us, and I'm seeing that, because I do know that we have a high population of transgender community members there, but I don't see any, was there any contact with any transgender individuals throughout the space? I'm a little worried about that, especially with it being out in South King County, and we do have a big population of of community members that do identify out there. So I just wanted to know, have you worked on any navigation towards that? Or what is that? I don't know. I see you do have that there, but I don't see any percentage of any contact. I'm a little worried about that.
So when you don't see a percentage or it says 0, there's an actual number tied to it. The problem is that it is probably a number under 11. And so that's part of the small number suppression where we're not allowed to provide that information if it's smaller than 11. It's when you look at it in the dashboard, it'll just be like an asterisk to be able to protect those individuals, because it is a smaller number of individuals, and it's easy to reverse engineer to like who that individual might be. And so we do have a number of transgender. It is probably under 11. As far as talking about engaging with them, I'm not clear. I don't know if Ryan, are you?
Yes. What was the question you had?
Regarding, I'm sorry, you can go down.
No, go ahead. I'm sorry.
I was going to say how we are continuing to engage with the transgender community, because there is a number of them that are affected and maybe being referred to this program, and just how are we continuing to try to engage with those individuals.
Yeah, I was actually looking at this slide, and I was trying to look ahead to our case management slide, because this is a topic that we've brought up internally, both through the small number suppression that we're required to put in place, but also making sure that when we're in the referral status, as being noted here, a lot of these are questions that you're asking on outreach, and people may not be as as really forthcoming and wanting to disclose until they've gained some trust. And we wanted to show that in that transition between the data we're capturing on the referral side and what we're able to share on the case management side. And I apologize for being a little distracted. I was writing a note to myself. I'm like, oh, well, we need to do a little more on this if this is not clear. I know there is outreach, but I can't speak to any specific examples off the top of my head.
And one thing to add, I know we're sharing statewide data right now, but the small number suppression gets especially important when we're talking about regional data and, the smaller regions where everybody knows each other. So it's just important for confidentiality, but of course creates a hiccup when we're trying to share the good work that RNP is doing with, different diverse populations.
Deontay?
Yeah, so my question is, especially with South King County being one of the most diverse areas, and seeing 37% unknown, can we touch a little bit on like, I don't know, that seems like the majority of the folks that y'all are in contact with. Can we, I don't know, I just want to know. And then also in the areas of the gender disbursement, it says unknown. Does that just, so no gender nor race was disclosed throughout the space?
Yeah, so that individual either did not want to disclose, or that that information was not captured during like the initial, like one of the encounters. You'll see a shift when it comes to case management later on. It'll shift downwards. It'll get smaller. We would like to see it a little bit smaller. So I know that myself, Ryan, we are we've been discussing that and how to approach BHASO as providers on trying to be able to capture that data as best as we can. We know it's difficult because when we're engaging with people, sometimes it's in crisis, and so that's not really on the forefront of their minds. They're trying to just engage with that individual and help them in that moment. But we're looking at different strategies on how to help individuals and try to capture that information because it is important. I know it's not super helpful, but I'm just hoping that, you know, we're continuing to make strides to collect this information and being able to help individuals. So. Yeah, Susan?
If it's okay, because and if it's not appropriate for a guest to respond, that's fine. But because it has to do with the areas of South King County, I'd love just to give my little bit of understanding.
Susan, do you want to just tell everyone who you are so that they?
Oh,
can...
yeah.
Yeah.
Sure. My name is Susan Pesey, and I'm the Recovery Navigator, a regional admin for King County. And yeah, I kind of understand these numbers, and I don't want them to go without both hearing the concern from Deontay, because I think it's both visual, and when anyone doesn't understand, that means maybe we can do a better job explaining the numbers. And I want to be able to respond that, like, at least in that area, I think that we are doing a good job respecting that the large number of unknown means that there is no forcing anyone to identify in a way that they're not comfortable with. And sometimes those questions don't even get asked in the beginning as a way to honor people. So I just wanted to call out that the first contact is it's at their discretion, and then when we get them fully engaged, that's when you'll see more identification. I know that the questions eventually get asked, but in the beginning, I would say that it's much less than later on. We really want to honor how much or how little the individual wants to engage.
Thank you. I really appreciate it. That's why I wanted you to state who you were, because I know who you are. And I always appreciate your opinion and your help in this, because you guys really are the ones out there doing the work and understand, you know, these numbers even more than us at times. And so thank you. I appreciate it. I think was it Blakos? Oh, Caleb.
We have Caleb. Yep, Caleb up.
Hi, a couple questions, and it may have been mentioned or it may come up, but just putting a few things out there. For me, these are interesting, but it leaves me with a lot of questions, and I know you all are still working on this, but I'm trying to understand, like, what's the variability across the state? What is the capacity? How does this relate to capacity? What are the staffing ratios? And I think the other thing that particularly be helpful for me is kind of this care cascade. When and how are we dropping folks? And then as we, through this care cascade from engagement to which level of case management they're getting, and then where we can be doing equity analyses as well and see if there's differences by those different groups. So I'm curious sort of whether those things are planned, whether you feel like you have the data elements there, and then also sort of this ability, among other things, for sort of this geographic comparison so we can see what the variability looks like.
So those are pretty much all the ideas that we're discussing internally. We would love to be able to follow an individual through referral and outreach and case management and see how they're engaging and how many times we're engaging. I know as far as capacity, majority of the RNPs are at or near capacity. I think there was a model, and that would have to be an internal discussion, a model of what a typical like RNP program kind of looks like, the different staffings and their different roles. But I would love to be able to at some point be able to give you guys a better picture of what it looks like for these RNPs. They are going out there, they are engaging. We're just, I know there's funding coming and there's funding happening, but they are at or near capacity at the moment. So you'll see that the numbers of people being enrolled kind of is dwindling from the beginning, while the case management is increasing. But it's slower now than it was at the beginning. And so
That's what I'm trying to understand a little bit is, are referrals slowing down? Is the capacity, are they at capacity? So now the upstream folks are knowing, well, then I might as well not refer them. Like, I don't understand what those system dynamics look like. And again, one way to look at that is kind of that care cascade.
Yeah. I know that we are still having a steady referrals coming in, a steady amount. Again, like I was trying to think of ideas for trend lines, and that might be one of them, of how many referrals have come in, throughout the months for the last state fiscal year, compared to how many are in case management, how many people are being enrolled in either or per month. But yeah, so those are a lot of questions that we're having internally, and hopefully when we're able to share regional data, it might give a better picture. It might clear up some things, but it also might pose more questions, regionally, like for regional pieces. But we are looking into all these things, and we're hoping that with the data integration platform that we might have more tools available to us to be able to present this in a better way.
Do any of the regions have more complete data that they could show as an example?
I currently we are have all that data. I'm hoping to hopefully when the public dashboard gets published, you guys will be able to see that regional data, and you might get more. I've noticed a little bit more complete with some regions compared to others. But for myself, like, I even have some questions in there. Again, it might clear up some things, but it also might pose more questions as well. And so we're just working through them as they come. But we are working towards something to have a clearer understanding of what's going on with RNP and the people we're serving.
And I'll just wrap here. I mean, I'll just sort of say, which I think you know already, is that, like, this is interesting, but I would argue it's not yet helpful. Like, I don't really know what to make of what's happening at this systems level in terms of what's the scale, what's the reach, what's the impact, what are the barriers. It's just hard to, can't see that yet. So I know you know that, but I just want to note that it's hard for us to monitor and give feedback on this, because we don't have, it sounds like you're not able to provide that information, but that's obviously essential, because we don't even know what our reach is, let alone the quality of the work. So thanks.
Yeah. And I know data takes time to really get a whole picture, and like for me, like at least like 5 years needs to really give a whole picture. But we're in year 2.5, and so we're still working slowly towards something, and yeah, it takes time. So I appreciate it, Caleb. Thank you.
Randy, you got Malika next?
Yep.
Okay.
So I ditto on everything that Caleb just said. And also, I just personally, like, as a person who has done crisis response, as a person who has collected data from people while they're in crisis, there's a way to do things in a respectful manner. And I have a problem with framing that the lack of data collection is being respectful of people, because when we look at the cascade of care, if data is not being collected at the beginning, those folks that don't continue to engage are just erased. And it looks like there's nothing to see here, no problem. And we're not able to see where folks are falling out of care, where care is not meeting the needs of the community. And it becomes an even deeper equity issue, and it continues to reinforce the health disparity. It just becomes one more layer in creating health disparity, and we don't even know it, because, like, we can't even look at it. We don't even have anything that tells us anything. So because it's just not there. So I mean, I totally am about moving at the speed of trust with participants, understanding that there are unique circumstances, but for it to be such an overwhelming portion, I mean, the lack of data is so overwhelming. And then the things that are being collected are not telling us anything, to repeat what Caleb just said, is just very concerning to me from an equity standpoint, from a care standpoint. So I don't think it's okay to just keep, there's a lot of money being spent here, and it's not okay to just say, well, it's going to take 5 years to figure it out. These are things that we're noticing now, and they can be addressed now. Thank you.
I appreciate it, Malika. Again, we're continuously having discussions with the ASOs and the providers on collecting this information. And I keep on having something to say. So there's also the piece of the quantitative versus qualitative data. When we have people come to speak, I think that really shows the progress that we're making to these individuals. We have a lot of people. I mean, we went from quarterly to now monthly of RNP success stories and program updates from the ASOs, because it's so huge, it's so profound, the things that we're doing for these individuals. And so right now the quantitative is not really supporting, but I really think that the qualitative information that we're getting is huge. Deontay?
And on a systems level, that is not, I mean, I'm glad individuals are getting helped, but this is not just, I mean, this is broader. Like, we're supposed to be engaging in system change. And if we cannot have data that shows us that this is working, we're not going to be able to continue to move forward. There's a lot of money being spent here.
And I think that that's one of my main concerns, like with looking at this graph. And I have heard great success stories, but I also have a big demographic. I have at least 5 friends right now that haven't gotten any access to the RNP program. That are currently going through the spaces of going through homelessness and incarceration. And I just know that I've heard great things from the RNP program, but I'm just concerned, even by looking at this graph, on the outreach to Black and Brown community members and our Indigenous community members. So I would love to see more data, as opposed to, hey, we have these coat of many colors, but it's not really representative of the community people who we know need it. Excuse me, I'm sorry.
All right, you want to continue, Malika?
Yeah, hands are still raised, so I wanted to make sure that.
I'm just a little choked.
No, I understand. That's the okay.
I mean, Deontay, if you have someone that's being affected, that's not being, being introduced or referred to RNP, you're more than welcome to message myself or Ryan, and we can have that conversation.
Yep, I could be able to send you their information after this call.
Thank you. Malika, did you still have your hand up for comment? Brianna, you want to continue?
Yes. I'll just add a quick note that of these individuals, 280 of them were made up of the Hispanic population in referral and outreach. You can go to the next slide. So you will notice a change here of contingency management does not appear on the screen. We have changed it to incentive-based encounters. This is because we realized that the contingency management in the context of how it's being captured in RNP doesn't fully align with the clinical definition of contingency management. While there are providers that are providing clinical contingency management, most of the time it's used as small tokens to encourage engagement and build rapport. We're using the term to tie back to the usage in the workbook until that's updated or the data integration platform. But we want to be clear that it's not always a true representation of contingency management for these reports. I also want to note multiple services provided is a huge number in the direct care services and referral to services made. That is based off of a couple of different things. So these workbooks, they typically have a multi-select option when it comes to direct care services and referral to services made. Typically, they're allowed to select multiple things like, peer support, transportation, appointment help, or, gift card or something, and do it all in one. But they, some providers are not able to utilize that option for some reason. We tried to work through the bugs, we couldn't, and so we made this an option for multiple services provided. They do provide information in a qualitative form in the notes section of all the things that they provided. And it could be, taking them down to Social Security to get the Social Security card, and then, making a referral to SUD while, providing them, recovery goal support at the same time. And so it's captured in a qualitative form currently. Again, we're hoping that when we have the data integration, they're able to make better selections so that we can see a whole picture of what they're being referred to. But the multiple services is currently a big number. Next slide. Although 252 clients for newly enrolled intensive case management and 400 in light case management, the referral and outreach this quarter, the case management team is currently overseeing more than 2,500 clients. The case management team is responsible for providing long-term support and assistance for these clients who are in case management status. That means that these cases require ongoing attention and support, sometimes extending over several months or even years. The case management team works closely with these clients to develop and implement personalized care plans that address their specific needs and goals. The level of referral and outreach and case management by recovery navigators varies across different regions. However, as I previously stated, these are at or near capacity. And of the case management, the 243 are of Hispanic origin. You go to the next slide. So these are snippets of the public, what will be the public dashboard. There's a lot of information here, a lot of information that you've seen on previous slides, but this is what the public dashboard is going to look like. I know I've previously shared, this looks vastly different. What I would ask is that you guys just reflect on these as we slowly go through them, and any comments or questions or feedback that you have that I can take back to the data team to, tweak this a little bit as we go. There's also an about this report where we have a chance to insert definitions that you'll see on these slides, or provide any how-tos of how to navigate this kind of dashboard. I know there's a date selector, or you can select by region. The date selector is very, very touchy. You can't do the second part without doing the first part first and moving it. It's very touchy, but I just wanted to get an idea of what you guys would like to see, any information that you would like to help explain this report to someone who might not be familiar. There is a lot of public public input, public, I guess, concern or feedback that people are going to want to see on these, and they might not understand as we understand, as we've been doing this work for a number of years now. But I wanted to give an opportunity to be able to, describe what we want to see in this report to any outsider or even for ourselves to help explain what it is that we're looking at. Sorry, I keep saying that Deontay, that the estimated clients is the estimated unique clients that is our as closely as possible to being able to calculate the number of individuals that we serve. We don't want to say it's 100% accurate. We're using as many, if you go, Rachel, can you go 2 slides? One more. The unique clients is calculated by a combination of, the provider 1 ID, client ID, first name, last name, alternate name, and birth date. Again, some people might have similar birth dates, similar like starting first name and starting last name, and sometimes that's all we get is a letter. And so it's, we're trying our best to make sure that we're dialing it down to an individual. But there is a lot of blank fields and there is a lot of, incomplete data. So we can only say it's estimated because it's not, we can't say that it's 100% accurate. We're probably at 98%, but it's not 100. So if anybody has any feedback or any things that they would like to see in this page. I'd be curious if it is possible for data to entail individuals with criminal records. I heard a lot of people express concerns about reoffenders in Washington State. I'm not entirely sure we're collecting that information, but it's something we can take back to the team and discuss. Hunter.
Well, I think but that's extremely important, right? Knowing how many community members have been impacted that have had a previous history. I think that's the real bulk of the program, right? On how it is helping to navigate folks, right? So I'm a little taken aback that there's no data specifically on that. Yeah.
I don't think it's a current point that we're collecting, but I'm sure that it could be something that we're going to in the future.
Is that Malika? And Malika, Deontay, are you good?
Is Deontay done? Or
I think so, yeah.
Yes, Malika, I'm done.
Okay. So in alignment with that question and in alignment with what Deontay has mentioned, it is, and the previous conversation that we were having, how systems are supposed to be, this is supposed to be a runway to system change and showing systems a different way to operate. The fact that we're not collecting any data on whether or not that's occurring and whether or not folks are experiencing that impact is a concern. I mean, part of the reason that, I know some of the people that Deontay is probably thinking about that would really benefit if that system navigation was happening. But system, not navigation, pardon me. Well, actually, yes, that. And then also system transformation was occurring because there's not the coordination happening within the systems outside of particular areas. Individuals are not able to receive that benefit of getting the continued support to be able to, it's cool to hand out a granola bar to people. It's cool to be able to get people into treatment when they want to do that. It's cool to do those things. And also when people have cases that they need help with that, getting that system coordination to occur with the prosecutors, with the law enforcement, so that everybody knows that that person is working on improving their life and that going back to jail for a violation or an infraction isn't going to help them, move along that cycle of behavior change, because they're right on the verge of getting their own housing. And that's going to be the big thing that stabilizes the person. When that communication isn't happening and we don't have a way to track it, we're not engaging in, we're not collecting data about how far along areas are in that process through their RMP programs, and how many individuals have been able to be successfully navigated through their criminal legal system issues. That is part of what RMP is supposed to be doing. That was why the legislature invested in it, because it was all related to the Pathways to Recovery bill initially. And they said, we're not going to pass that bill because we recognize that we're not to the place where we have a statewide system of support for people, nor do we have the systems built out to be able to support people because people were viewing arrest as a support. So if we're not tracking whether or not that other piece is occurring, then we don't have the information we need to figure out how to move that forward, make those impacts, so that we can really engage in doing something different and creating the transformation that people need in order to get stable. So, when we're talking about data, we need to be looking at all of those individuals that are a part of what is supposed to be that policy coordination group that is happening through each RMP program, and those operational work groups. What changes are occurring, and how is that impacting the individuals that are in service, and which individuals are getting the benefit of service, because we have actual accurate data on who they are. Otherwise, we just keep doing crisis response, and that is not coordinated long-term case management.
Thank you, Malika. I appreciate your comments. And again, we'll
I'm not actually sure about that, but I think that it is something that we need to be thinking about.
No, I appreciate it. And again, we are going to be looking into that and trying to integrate that into our next iteration of being able to capture that information. And I'm sure Ryan is taking note of having those conversations with those groups and the BHA associate providers. So thank you. I really appreciate it.
Did you have a comment?
Yeah, I just raised my hand as well. Wanted to point out that I know Michelle had posted in the chat that there is some data capturing that will be changing when the data integration platform is put in place, which is definitely a future project. There are some limitations of the current platform, as we've acknowledged over time. Just because the workbook does not capture this as a discrete data point does not mean it's not captured at all. A lot of this information is something that would be part of the case management that individuals receive. And it might be in their case management notes, it might be elsewhere, but that doesn't necessarily mean it translates easily into something we can put on the data dashboard. So I really would push back a little bit on the idea that it's not something we're interested in or not something that is being captured or supported, just that it may not be part of this presentation. I think a lot of good questions and comments came out today that we can look to see how we can improve that. But I also want to point out that Brianna's presenting information, and I do want to enforce people should really maybe be a little bit more respectful in how they approach that. Malika, I'm going to call you out specifically, and you and I can address this separately, but I feel like you were kind of rude to that. And I want to point out that we're trying to present information, take that back, and we do actually appreciate the input we're receiving today. It is important, and it's affecting people's lives. And when we say that, we're honest about it. So I just want to stand up for my coworker here and just say we're trying to do our best and get this information and get the system into a better place. RNP does not have the legal system supports that the lead model also has. So there are some gaps in the service delivery that we can present. A lot of the case managers do help with legal system coordination, but as peers themselves, they may not have the expertise to really push that as a specific issue. That is something we've addressed with some of our system partners over time, and it's something we'll continue to do because we recognize how vital this can be. But that's a lot of moving parts in what we're trying to address in this. So I just wanted to comment to that, and then I'll step back.
So we are over time on this.
If I can, real quick, I just want to be able to say something really quick, Mr. Keith Ryan. I would say, how dare you? You know, us as a collective, we come here and we have tough conversations. And a lot of those tough conversations came into the wonderful SURSAC recommendations that we have. When we don't see data and we know that there's a community of community people that are impacted out there, we are going to speak our mind about the lived experiences that we're around every day, that we're out there helping to navigate. We respect everybody in the RNP program. But looking at the data that we see, it's just we just don't see the data here that shows how community folks are being navigated, and that's harmful. I don't think that that's rude at all. And how dare you even challenge someone like Malika or anybody on this line? We are community folks. We're community folks that are trying to reach to the greater good, and I respect everybody on this line. But I don't think that calling someone out in this space was respectful at all. And I'm just going to have to push back on that. And again, all the things that we were stating on this line was not in a disrespect towards anybody that's working in the areas of RNP. We know that people are out there.
Deontay.
Yeah.
Thank you for your comments. I think we got the gist of that. Is there anything really we need to talk about here now? Malika, do you have another comment?
There is actually. There is something to talk about here. In this forum, I am a member of this body. One,
you are.
We are being asked questions. We are being asked questions about what we think would make things work better, and what we think should. And we were directly asked by Brianna what we thought would improve the data collection. I delivered those answers, and Mr. Ryan Keith has an issue with anybody having a direct tone about what they think should occur. And yes, Ryan, we can definitely take that up outside of this meeting. However, it is inappropriate for you as a representative of HCA to try and correct me when I am answering a question that was directly asked of this body that I have been appointed to by the Healthcare Authority to provide my expertise.
Understood.
So I will let your supervisor deal with you.
All right. So we, again, are over time in this topic. Obviously, we have some things to work out here in the near future. Brianna, how are we doing on?
I'm all done, Blake. Thank you. I really appreciate it. And again, I appreciate everyone's time and their concerns and comments and feedback. I will be taking it back and discussing it not only internally with our RNP folks, but also with the data team as well to see what we can do, and also including in our conversations when we talk about the data integration platform. So thank you, everybody.
Okay. Thank you. Next up, if there's no other comments, all right. Next up, I believe, sorry, what's my agenda here? We have James Dixon from North Sound, BH, Behavioral Health ASO. James, are you ready to go?
All right. Hello. Thanks, everybody.
Yeah,
So I'm James Dixon. I'm James Dixon, the RMP Administrator for North Sound Region. We have 5 RMP programs in our region, and along with collaborating with 2 lead programs. So today we're going to hear from Compass Health, our RMP provider for San Juan County. Teresa Tilton and Paul Lewis will talk about some successes, challenges, and complexities of working across multiple islands. Teresa Tilton, the program manager, will start things off for us. Hi, Teresa.
Good morning, everyone. I'm Teresa. Complexities, I just traveled on the ferry to get to Friday Harbor. So most of the meeting was done by boat. and I made it to the office in time to talk to you. San Juan is made up of 4 ferry accessible islands and then many more islands that are not accessible but inhabited by residents. We have staff on Lopez, San Juan, and Orcas Island, but we also are required to travel wherever there are clients that need our assistance. So we travel to the ferry accessible islands. We also travel by charter boat to other islands when needed. And that, as you all know, the ferry system is not perfect. It gets canceled a lot of late boats, a lot of late nights. So that just kind of adds to the complexity of working here, but we're all kind of used to it. And luckily the clients and residents also are. And so we get a lot of grace when we have to cancel or do a meeting by phone because of the ferry system. And we've been operating for almost 2 years in July. We have 5 staff. We have 2 case managers and 3 peer support specialists. I'm the program manager, and Paul Lewis is the program supervisor. And this has been really game changing for the islands because we did not have a case management service, and especially for those that have a lot of barriers to receiving service because we don't have a lot of services in the islands. We have a lot of homegrown type agencies that are wonderful. We have Compass Health provides mental health. I'm also the program manager of the crisis services in the islands. So we're responsible for wearing many hats in the community. But the case management and meeting people where they are, going to where they are, has really been very, very helpful. It's been a challenge to coordinate with the courts because, as you imagine, we don't have as many cases as other places. Plus, just the support the court needs and understanding the program, I think, is pretty difficult and hard to get in there. Also, at the court system, you know, judges and prosecutors wear many hats. But slowly but surely, we're receiving those referrals, but many of our referrals come from the crisis system and from the community. That's how we receive most of our clients. We were able to participate in a sequential intercept mapping. Here in San Juan County, the courts were awarded this grant. And what that means is it's a project to help San Juan County in general understand all the services that are available, how to connect with those services, and then also see the gaps in the services that we have and create little subcommittees to try to work on those in a reasonable manner. So it's taking a lot of the siloed agencies that we have island to island or even on the same island and trying to get us to work together in a better way. We currently do work together, but it can seem that it's hard to talk to each other on a regular basis. So hopefully through this process that the courts were awarded, we'll get a lot more court participation, maybe even therapeutic courts. And that's what we're looking forward to, is just connecting in the San Juan Islands as a whole for the good of our clients. And I'll now turn it over to Paul Lewis, the program supervisor.
Good morning, everyone. Thanks for hosting us here this morning. I wanted to speak on 2 different topics, just a little more on the sequential intercept modeling project that we went through, or mapping project, just to state how important it was to take this step in San Juan County and engage a lot more stakeholders in the county in terms of how we respond to different situations. Just to give a little bit more information, I wanted to just share briefly, let's see if I can get to it quickly, what the intercept is actually looking at like. So I don't know if people can see this picture, but basically the intercept model is trying to map where intercepts happen along various stages, from community services to law enforcement to arrests, courts, and then treatment and reentry, and maybe intercept 5 is community corrections. we're part of a pilot project that was we applied for, and our local judge, Carolyn Jewett, applied for San Juan County, reached out to a lot of stakeholders in the county, and then wrote a letter, and we were awarded this grant that also provides some financial resources, but mostly the initial process was to get a lot of community members, stakeholders, agencies, representatives from all over the county into the room and talk about these intercepts, where they happen. And this was particularly important. A couple of the facilitators came from law enforcement backgrounds, and that was one of the most important things about this meeting was getting law enforcement into the room. And something that was abundantly clear from the outset of the meeting is how some services and entities can be siloed, and their cultures are very different from each other. And so having those conversations in one room was extremely important. The other part, kind of speaking to our conversation early, was about data collection, like being able to capture intercepts in the community that involve different kinds of law enforcement engagement, whether it's substance use, domestic, physical assaults, all manner of things, but have data collection, and how do we share that data amongst each other in moving forward. And then as part of the 2-day process, what was produced is kind of a number of different work groups who will continue on over the next year, looking at various ways to kind of move our project forward. And this is what I'm sharing now is the action plan that came out of San Juan County. One, and I guess I don't know how helpful this is to look at for everyone, but basically all these action steps have a lead and a committee and have a date in which we're going to produce something to share with the rest of the group. And part of it, one was about information sharing and having a clearinghouse for resources that can be shared in the county. Another was to create and formulate a process, like how can this continue? How can these conversations continue? Funding resources, of course. One of the main topics was how do we share information that's HIPAA compliant? Like how do in the course of data collection, since there are so many stakeholders involved, how do we share information but still maintain confidentiality for our clients? And so that's a community care coordination and release of information that can be shared and respected among a lot of the different stakeholders that are working, which is going to require memorandums of agreement and a lot of working nuts and bolts in the background. Also a significant topic was the larger category of warm handoffs. How do we do how does that happen, and who speaks to who, and what is the most appropriate first or zero intercept to happen that's going to connect people most rapidly to the resources that are appropriate to them. So let's see, I think, and then another action item was paramedicine. There is a paramedicine medication management team on one island, but not the other 2 islands. One island has one hospital district. Well, there's actually 3 different hospital districts within one county. And so it gets very confusing in terms of sharing information and making referrals for treatment and things like that. And so that's just another it's not necessarily an obstacle, but it's definitely something to work on within the county. And then, of course, one of the major issues, and this is true for all counties, I think, in Washington State and maybe nationwide, is just housing. You know, we don't have transitional housing in San Juan County. We don't have sober housing in San Juan County. We don't have a shelter in San Juan County. And so that makes it really difficult to create linkages within the system that follow a person through their treatment to something else. So I wanted to share this just as a process that we're engaged in San Juan County to help strengthen those linkages between all our providers. And it was great having all those folks in the room. One of the best things I would say is that there was a gentleman in the room who had gone through a very complex treatment journey, I guess you would call it, both on island and off island. And he was in recovery and being training as a peer during the time of this SIM modeling project. And it was just amazing for the whole group of providers, a lot of whom are professionals, to hear this voice of a peer or a person with lived experience speak to the whole group, not only about the successes, but also about the challenges of receiving, getting to treatment and navigating the complex systems that are out there. So that's one thing I wanted to speak to. And then I wanted to share a success story that illustrates a number of linkages in the community, and also I think, given the conversation at the end of the data presentation, also might illustrate the complexity of the number of handoffs that happen in someone's treatment along the way. I'm going to share a little demographic information, hopefully not too much that's identifying, but I think it's important. The individual that we worked with was Native American, middle-aged, had previously tribal affiliations in the Southwest, but had been disengaged from those affiliations for quite some time. This individual was known to the community in the county, but had a long history of trauma, of arrest, sexual assault, physical assault, extremely low resource individual, longstanding alcohol dependency, and longstanding polysubstance use dependency. They didn't have any health insurance, had never tried to get health insurance, and they had never received any treatment of any kind, you know, up to the time we had engagement, which was pretty much in the beginning of our program in 2022. And initially, I guess the zero intercept would be that there was a number of different crisis engagements with this individual, and then referral came to R&P, and our staff started doing outreach. This was at a time when the client had very marginal housing. It was basically a trailer in the woods, distant from the services in the community. The housing was provided by a community member, so the person being known to the community was being supported by a community member with housing. They were also known. Another really important linkage in the San Juan Islands is a system called the Family Resource Centers. And there's one resource center on each of the major islands, Lopez, San Juan, and Orcas. They work with families, they work with children, they sponsor mentor programs, They help people connect, apply for medical insurance, apply for housing, a lot of different services. And RNP program here in San Juan County works very closely with them. And it's really all about relationship, and particularly in this case, developing trust took a long time. And in fact, RNP had an engagement with this individual for about just a few months' time, and then we lost contact with them, where we were reaching out, no response. Clearly, there was a substance addiction situation that was operative. They ended up losing their housing, were homeless for a period of time, and had law enforcement engagement. And this is also illustrates the absolute importance of law enforcement cooperation in certain circumstances. And it's that line between what treatment is mandated for an individual and what is voluntary. I think the creation of RNP was to have engagements that are fully voluntary, where there's trust created with an individual, and we're helping them move on to a place where they choose for themselves to engage in treatment. I mean, this individual had law enforcement contact in which they probably could have clearly been referred to crisis services and referred to substance treatment, maybe even detained for substance treatment, but they were arrested instead and ended up in law enforcement hands, and then ended up, being in a system in which they had to respond to probation requirements, essentially. Within Compass Health, we have an SUD treatment program that provides assessments for individuals. That's an important linkage between probationary services and getting people into treatment, because we're able to do assessments in-house in the county and then work on getting someone into appropriate services. After that period, they were re-referred to RNP, and we re-engaged with this individual, and essentially we're working with probationary services and the Family Resource Center and other entities to find appropriate treatment for the individual. And this is where what's happening in the entire state is really important, because there is I want to sort of give a shout out to an entity called the Northwest Tribal Treatment Center. It's in Southwest Washington, that provides culturally congruent treatment for Native American individuals, with activities, cultural supports, and like sweat lodges and crafts and things that are directly engaging Native American people and connecting to their culture. The individual spent 60 days at this treatment center, and then transitioned to another place that I'll also want to give kudos to. Is called Friendship House in Mount Vernon, Washington, that is a sober living house. And the individual was able to be at the Friendship House for a month immediately following their treatment. And again, I can't overemphasize the importance of these warm handoffs within the system, where someone can go immediately from treatment to another safe environment. Because one of the things that I think we know is sometimes people go into treatment and then they come back to the community and they're in the same environment that they were when they left. And the risk of relapse in those situations is just exponential. So they spent a month there and then engaged in services with a local tribe and also another entity that is in Mount Vernon or in Anacortes, Washington, that is a tribal treatment center called Dijwalik. And they provide substance use treatment, mental health services. They have a methadone clinic, all things that we don't have in the islands, but thankfully is pretty close by. So I guess that I wanted to illustrate like the number of different steps that were involved. I had a conversation with our client who still reaches out to our staff, our RNP staff on occasion. They love getting pictures from us about what we're doing in the islands. And it's one of those, very, for me as an RNP supervisor and managing peer staff is just so heartwarming, because that's part of, it's not reward per se, but just like, oh, this actually worked. We were able to be one piece in a puzzle to moving individuals on through all these different steps. And we're still in contact with them. We haven't lost contact with them. This individual that we're talking about has, let's see, I want to read just a couple things from our conversation that might be illustrative. Now I'm going to meetings 2 to 3 times per week, to classes 4 times per week. I have house tours, house meetings, a curfew, a one-to-one with a counselor here at the house, and I do 40 hours of productive time per week in order to live here. So that's part of the housing requirement with the tribe. I've been working hard. I'm 213 days clean and sober today. I'm feeling good about it. I'm glad that I am. My recovery means everything to me. It's month to month. It's a temporary base. I can be here for up to a year. I'm looking for a place of my own. I have to look for a place every week. And I reflected back to them. Well, let's see, what do I want to say about those words? Given where this person came from, that level of clarity and reflection about their experience is extraordinary. Being isolated, being ashamed of their history and past, not having any services at all previous to these engagements just speaks so highly of this individual. They actually shared with me that, well, I had a roommate that was the worst roommate I ever had for 3 months in this housing situation, but I made it through. And this person required a lot of care. And again, it's just illustrative of the growth of this individual within 1 year of time and where they find themselves right now. I asked them direct permission if we could share a little bit about their story here at the meeting, which they gave. And then I said that we're meeting with a state group called SURSAC, the Substance Use Recovery Services Advisory Committee. And this is their response to having their story shared. Said, I'm so grateful for these programs, for all the help I didn't know was there. I'm grateful for those of you who work with us and for us, giving us the hope and faith, the encouragement and support we need. You are appreciated by so many. I can honestly say that. I'm around a lot of us on that road. We in recovery have love for you all. That is a direct quote from this individual. Just as a data point, we had 86 different case management notes during the time that we were involved with this person. And a lot of those were direct engagements. And then, for our RNP program, which is still really, I would say in its infancy. We've had nearly 650 case management notes during that time. And we've served, I don't know, well over 60 individuals during the last couple years. There are a lot of challenges, not the least of which is this ongoing work with law enforcement, agreements within the court system, so that zero intercepts can happen and be more directly, people can be more directly referred to treatment as opposed to being risk arrest and other interventions that are really counterproductive to people's well-being and recovery. And this is San Juan County. You know, we have unique challenges. I know all the different counties have very unique challenges as well. Ours really has a lot to do with being separated by water and not having public transports. We don't have adult protective services or child protective services, individuals that are in the islands. The Department of Health and Human Services does not have an office within county. So those are things that we're working with, and we don't have treatment centers within county too. So I hope that was gave you a picture of what we're doing in San Juan County and the work that we're continuing to do. And I really appreciate the opportunity to speak to you all.
Thank you so
And I'll
much
take
for the presentation.
any questions.
Yeah.
Yeah, actually.
Yeah, we have time for a couple questions, a couple quick questions. Anyone have a question? Malika, go ahead.
I just wanted to say thank you for your great work that you're doing out there, because there's such a like lack of services. There was such a lack of services, and the gap that you all are filling is felt, and you all are doing a really great job. So I want to acknowledge that. North Sound is amazing.
Thank you
That
so
whole
much.
region.
Thank you. Any other questions or comments? Okay. Again, thank you so much for your presentation. Appreciate your time and your efforts. Oh, Deontay, go ahead.
Yes, thank y'all so much for your presentation. I was wondering if you can put some of your contact information in the chat or any information where we can find y'all.
You bet.
Thank you so much.
Thank you. Okay, last call for questions. All right, thank you again. Thank you so much. Kelly, back to you. We didn't have any walk-on items, so yeah. Again, thank you.
Thank you, Blake. I just have two quick things. Thank you for all the presenters. You guys did great today. Thank you so much for presenting. I just have two things to bring up. One is the agenda for the next SURSAC meeting, and then also two, it was brought up if I don't know if anybody's ever heard of the Washington Speaks Statewide Peer Engagement and Advocacy Keynote Speaker. Stands for Washington Speaks, and they get trained in how to speak in groups like this. They actually have someone that goes to the CRIS committee, and they speak there, and they have a speaker there, and they get to share. You get to hear someone with lived experience, which is amazing. And I was bringing it to the group to see if this is something we wanted to implement here at SURSAC. Okay. I'll go ahead and send an email, and then I can get your guys' responses back on an email basis and see what you guys think about it. I'll send you the web link so you guys can go ahead and look at that website as well. I'm going to go ahead and share the okay. So next agenda, we have Tony, Michelle, and myself doing the roll call and such. Public comment will be Blake. We have Chloe coming for the SURS plan, implementation update and consultation for DCYF, training for caregivers of youth with SUD, 30 minutes. And then we have the SURS plan implementation update consultation, employment education pathways pre-program from Lisa Bennett. And then this was brought up a couple sessions ago, and we finally got it on the calendar. DCYF on the 6109 follow-up from a couple months ago. We have Vicky coming in to go ahead and present on that. And then the RMP highlight is to be determined at this time. Is there any questions right now on the current SURSAC agenda? This is just the preliminary. Of course, you guys will get the this agenda and then the final one, of course, and everything. This is for July.
Will there be an opportunity for the group to be able to ask some questions, or maybe develop some specific questions around 6109, or are we just going to be getting a generalized update?
I think right now it was a generalized update. I can ask about seeing if we can make room to the schedule for questions.
Yeah, there should be time for questions.
Okay.
Yeah.
Yeah.
If you have questions ahead of time that we can relay to the presenter, they can try to address it in the presentation.
Okay.
And otherwise, there will be Q&A after the presentation. So if there's anything that you want to know specifically that you want to forward to Kelly to relay to the presenter, that would be welcome.
All right, thanks.
Thank you, Malika. Okay, well, thank you, everybody. Appreciate it. Appreciate everything, and pass it back to Blake.
Okay. Thank you for the meeting today, and we'll see you next month. Y'all take care. Thank you.
Can I say something really
Yeah.
quick? Actually,
you bet.
so I want to make sure that people understand that when I ask pointed questions, I'm not critiquing Brianna. And Brianna, I want to recognize that you put a lot of work into developing the reports that you did. So I'm sure that the exchange that occurred will be politicized. I'll be pathologized as being that rude Black lady, all the things. But I want to let you know, Brianna, that I do see the work that you put into the process. I was answering the questions, and my concern is 3 years, and this is not your responsibility, Brianna. This is about an HCA systems level conversation, that it has been 3 years and we continue to have the same data issues. That is not a you issue, that is a system issue. And my pointed questions and my frustration is not about you as an individual, it's about the system as a whole and about how we must do better in order for people to get the care that they need. So I just want to be on the record to make that very clear. And it is not okay that that sort of feedback is used. And when I said, I'm not sure, it wasn't about you as an individual, it was about the system that you work in. So I just want to make that abundantly clear. We all need to be doing better so that people do not fall through the cracks. And I will continue to be passionate about that.
No, I appreciate you saying that, Malika. I really do. And yeah, I feel the same. And it's just keep on trying to push that brick wall until it moves, right? And so, I do take it back. I do talk with my team, and we try to do the best that we can. And so I do appreciate your feedback, and it doesn't go unheard. It stays on my radar until we can get some kind of resolution. So thank you.
All right. Thank you so much. We'll see you next month. Bye-bye.